Hi, everyone. Welcome back to another Rafael Medina Subspecialty Neurology VMR. We are here with a star guest today from neurology, Dr. Zeigler, Gwen, who is a mentor, a dear friend of mine, and I'm so excited to have her here join us finally. Just to give you a brief introduction, my name is Vale. I am originally from Lima, Peru, where I'm also calling from. I'm applying to the match on neurology this year. Really excited to become a neurologist soon. And yeah, I'm just going to pass the mic to Dr. Ziegler so that she can introduce herself.
Hi, I'm Dr. Gwen Zeigler. I am a general neurologist at Albany Medical College, Albany Medical Center, and I am excited to be here today.
The honor is all ours, Gwen. We're so happy to have you here. So now I'm going to pass the mic to another star member of our team, Jeffrey. Please say a little bit about yourself and you're presenting the case today. So it's going to be a good one.
Hey, yeah, thanks so much for having me back. I'm Jeffrey. I'm one of the rheumatologists at Duke, with one of my interests being overlap between neurology and rheumatology. So I have a actually dedicated clinic where I see patients together with neurology once a month. And I'm very excited to be able to present a case today.
Amazing. I see you when smiling, so I think this is going to be an amazing session. And this wouldn't be possible without the help of the team backstage. So I'm gonna just ask Hans and Zimi so that they can introduce themselves. They are the ones that are doing the scribing and teaching points today.
No, very excited for Jeffrey's case. They're always so fascinating and looking forward to discussion. And welcome, Dr. Zeigler. Very happy to have you here today with us.
Yeah, my name is Hans and I'm doing the teaching points, and I think we'll have a lot of learning today. These are great cases. I'm excited to see what's going to be.
Amazing. So I think we can put the whiteboard up and we're ready to go. Just to give you a little bit of context, when uh, I think we talked a little bit about this, but because I'm junior, way junior, way more junior than you in my training and in my knowledge, I think it would be appropriate for me to kind of start maybe share my thoughts so that you can, just teach based on that and complement and maybe, fix some of my knowledge gaps there, if that's okay.
I'm happy to work with you according to however you feel best. Yes.
Perfect. Okay, Jeffrey, we're ready for your first aliquot.
Okay, so there's going to be a really rich history. So in the first aliquot, I'm just going to present the chief complaint. And this chief complaint, I will explain a little bit further with details. So the chief complaint is encephalopathy. And obviously, we use this word a lot and it can mean a lot of different things. So I'll just give you all the different things that this encephalopathy covers. And I'll say it's a 21-year-old man with acute encephalopathy. And so essentially, what's happened in a course of about maybe 1 to 2 weeks is that he's had intermittent episodes that are characterized by insomnia, agitation, and both visual and auditory hallucinations. Mind you, this has never happened before. And in addition to these symptoms, the encephalopathy is also associated with headache, with neck stiffness, a dizziness sensation, with actually he describes it as a sensation of the room not spinning, but bouncing up and down, or in diagonally, resulting in vomiting afterwards. Difficulty walking sometimes, leading to mechanical falls. He says he trips over things, and issues with talking that are noticed by people around him, as in he may answer very slowly and tangentially, or he may not even answer at all. And this is the chief complaint.
Amazing. Well, this is super rich. Thank you so much, Jeffrey. And just to clarify, in between the episodes, is he completely fine, like back to baseline?
He is not completely back to baseline, but I'll explain the next aliquot a little bit more about the history.
Okay, awesome. So I'll just start with some of my thoughts. I think we have a fairly young person with an acute time onset of diffuse symptoms, neurological symptoms. I think the intermittent nature of his presentation really makes me jump into like three things. The first one being the possibility of seizures because of its episodic, then the other one being migraines, and maybe the third one being some sort of spasm, like vascular spasm, leading to transient symptoms. And I think when it comes to localizing this presentation, we have insomnia, like sleep disorder, hallucinations, neck stiffness, dizziness that is quite interesting, associated with vomiting and some difficulty walking. When it comes to like sleep issues, I usually localize more to like the hippocampus or like the Paget circuit, that it's more like on the deep matter of our brain, and that could also be compatible with some of the, you know, diffuse headache, the difficulty walking. I would be more interested to see if it's like an ataxia type of presentation, because that for sure would be very helpful to localize, maybe to the posterior fossa cerebellum. And I think that dizziness, it does not seem to me like typical vertigo, but more so like maybe a perceptual process. And that with the auditory and visual color hallucinations make me think about the occipitotemporal region, because of the visual component more like the occipital lobe, and more the auditory more like the temporal lobe. So I'm wondering if is this something, you know, diffuse in the brain, like brain on fire, for example, or if this is something multifocal, like, for example, a meningeal process as well, or like a vascular spasmic process affecting various areas at the same time. So yeah, that's what I'm thinking. What are you thinking, Dr. Zeigler?
Yes, I love your thought process there. So we're talking about sudden acute onset, and I agree with seizures certainly being within the range of everything that's happening. You're talking about a diffuse encephalopathy, dealing with either somewhere at the brainstem or a whole cortical process. And when you're talking about neck stiffness, I don't mean to go down right there too. Often you're wondering if there's any kind of meningeal irritation. We're often dealing with things like any kind of subarachnoid bleed would be one thing that you're kind of looking at, versus some sort of inflammation that occurs. And it's quite often fluctuating. And dealing with insomnia, I mean, you can get certainly subcortical issues tend to be a little bit more common with that. But the hallucinations that are occurring with the auditory and visual hallucinations, you're talking about acute onset. This is also where I'm wanting to make sure there is nothing toxic that is occurring, nothing new that's been introduced, any kind of hallucinogen, any kind of drug, or anything that is reactive that is occurring with any toxic or any drug-induced state. You'd be looking at certain metabolic issues are not commonly going to happen that quickly there, but you'd be looking for anything else that would be occurring. An inflammatory state, when we're talking anything subacute, you're wondering about whether there would be any sort of autoimmune process that would be occurring. As with that, and talking about the bouncing sensation that occurs. And I mean, I'd like a little bit more clarification. I agree, it doesn't agree with much with vertigo. You wonder whether or not there could be something that could be happening that would be perceptual, which is still occurring. Talking about the temporal occipital lobe that would be occurring, auditory hallucinations, visual hallucinations, which sound very cortical in nature by themselves. We're at least dealing with a diffuse process that is occurring, or multifocal that is occurring as well. Dealing with the unsteadiness, the walking difficulties. We say that the gait is the most important part of the neurological examination because of all the components it tests. And so I really like it talking about whether or not there is any ataxia that occurs with it. But what the component of the unsteadiness would be very important, because there's a lot of rich information that occurs with that. And certainly, if it's vascular, could it be like you're talking about a spasm? But I think a bleed is a concern. With that, you tend to see a lot more focal difficulties that could be happening, unless you're dealing with the subarachnoid space that would be occurring as well. So this is a very interesting case that is happening and is occurring as well. So I'm interested to hear a little bit more. So going over the localization, I'd certainly think that at least you get a lot of diffuse or multifocal brain involvement, which can happen with the postictal state as well, and possibly subcortical and meningeal. Meningeal are some of the bigger components that we're hearing so far.
Love it.
All right. I'll continue with the history. So, for the internal members of Clinical Problem Solvers, I'd like to title the cases. So, the title of this case is Three Stories. And the reason is because we can't really get much history from the patient. So, we have three different histories, and they're all kind of different histories of the same timeline, about 2 weeks. So, the first history is the history from the parents. Now, we talked to the parents, and the parents said that basically he told them that he went to eat pizza with his college friends. They all got a GI illness afterwards, some food poisoning, had some headache, nausea, vomiting, diarrhea, felt sick. All of his friends got better within 1 week, but because he didn't get better, he went to see his doctor. He still had like nausea, GI symptoms, headache at that time. And then they reported he told them that he started on Zofran, and then the next day is when he actually developed this like weird confusion. And then they later find out that his roommates found him passed out with frothing of mouth on the sofa in the living room, and that's when he got sent to the hospital. So that's the first story for the parents. According to his roommates, they said that they were unsure whether he had food poisoning at all. He came back one night at 3 a.m., and at that time, he was apparently drunk. He appeared drunk, he was stumbling, he was loud. They all woke up. And the next day, he appeared to be hungover. He told them that he was having food poisoning, but they saw that he has his eyes injected, and they could smell that he had marijuana. So they had suspected that he's probably been smoking marijuana. And over the next couple of days, they were unsure because he didn't come out of his room very often, but because they could smell, they were suspecting he kept smoking marijuana. And so they were mostly worried about a marijuana toxicity, and that's why they brought him to the ER. From the PCP notes that we see, he did see the PCP 1 week after this quote unquote viral gastroenteritis. And at that time, he was having bad insomnia and general malaise. The other symptoms were GI and a flu-like illness. On the exam, there was left upper quadrant abdominal pain, and he had a fever to 100.6. So he was actually sent to the ER at that time. The ER evaluated him. They saw he was like mildly tachycardic. He had a small AKI with a creatinine of 1.4, mildly hyponatremic. All in all, essentially, they said that he probably just had hypovolemia. He was just really dehydrated. And they gave him IV fluids and Zofran at that time and sent him home. At that time, they did get the viral infectious studies, including a panel, a swab on the nose, testing for strep, testing for flu COVID, testing for EBV. They also got blood cultures in the ER and urine cultures, and all of those were normal. And finally, the piece of history from the patient himself is intermittently, as I said, he didn't go back to baseline, but he was able to converse. He would only be able to converse sometimes. And during these times, he said the main issue he was dealing with was insomnia. And it seemed like he was trying to use the marijuana to help him feel relaxed because he felt like very anxious, dizzy, and just he couldn't sleep for like many days in a row. And that is the HPI.
Wow, this is fascinating. Okay. I think we are in a case of like chicken or the egg. We're not really sure what came first and what came like as a consequence of it. At first I was thinking, oh, could the marijuana cause, I know marijuana can sometimes cause psychosis like episode. However, I think I'm also questioning if, as Jeffrey mentioned in the last part of his presentation, the marijuana was like a coping mechanism for an insomnia that could be part of the underlying, maybe more subacute going process. I think, well, as I said, complications of marijuana, I know about this like psychosis like episode. However, I'm not sure if it could account for more, um, we see more like neurological or slash not so much psychosis like signs here, like the visual component of hallucinations, the dizziness, and the hopefully we're going to see some objective signs on the examination, as well as the possibility of a seizure happening when he was found down. Then I'm also wondering if this component of infection could account for his presentation now, which is we are not sure if he in fact had food poisoning or not. I think post-infectious things that could happen in the brain include, like I saw someone mention on the chat ADEM, which I think it's a great possibility if we confirm that this is an acute going episode. However, I'm not really sure if that's confirmed, and even if it was, we don't necessarily need an infectious process to trigger a diffuse encephalopathy type of presentation. So yeah, I'm not really sure what to make of it, like to have any conclusions on what was before and what was then later. So yeah, we'd love to hear from you, Gwen. I feel like I'm rambling here, but we'd love to hear your thoughts.
Yeah, absolutely. Yeah, no, it's a really great case overall. Um, I do wonder whether or not a component with the Zofran could be part of the picture. And one of the things that does come to mind is could a lot more that's going on than just the serotonin. Just testing here.
Yeah, I think we can hear you now better.
You can hear me now better? Let me see if I could just make this a little bit more reliable. It'll just take me 2 seconds. Okay, I apologize. So you want me to start again from the beginning of where I was?
Yes, please.
Okay, give me 2 seconds just to work something out. There we go. Now, hopefully this will be, can you hear me well now? Just to make it a little bit more reliable.
Yes.
Okay. Okay, I apologize. So, yeah, so a good thought process, a good way to go about it. I do wonder whether or not there could have been a component with the Zofran being added, like with the serotonin, for example. This doesn't overall sound just like serotonin syndrome. Mind you, we do get hallucinations in the setting of with the THC that does occur. And introducing a food component with it too. We're sounding like could there be something that be external? Could there be something infectious, as you're mentioning, that would be occurring? But nothing that I would be wondering that could be happening. Could we be getting a autoimmune inflammatory reaction to an external substance like a marijuana? What was it? What was it laced with? And occurring because we're getting more that's occurring right here too. We get a lot of vital signs that are abnormal with it. So I mean, the same the Zofran would work with the serotonin H3 pathway, and marijuana would work with some of the serotonergic pathways. I think that there's more involved than just simply the ingestion that's occurring. There's a lot more systems that are involved, but a lot of the systemic symptoms would certainly explain a lot of the can help us explain a lot of the diffuse symptoms that are occurring. But I do think that there's more that's going on here too. Things some people have mentioned certain autoimmune conditions like NMDA encephalitis, which can cause a lot of psychosis. You can get seizures with that. You can get hallucinations with that. You don't necessarily get fever with that as much. And somebody else, as you mentioned, had mentioned ADEM here. And I apologize. Would you say that blood pressure was high with that patient, or was it kind of low there? Because you get the
His blood pressure was normal. He was just a little bit tachycardic.
tachycardic. And I do wonder, and so you're talking about, was there any kind of lightheadedness with standing up? There's a lot of things going on with the dizziness component. There's a lot more going on than would be with the dysautonomia, mind you. That does occur, but that would wonder if that would be part of the systemic conditions that happened. So this is an interesting case in which we're not getting one clear focal lesions and is quite diffuse. With the neck pain that would come on, that would, of course, make me a little bit concerned. Could there be something that's viral that is occurring? And with how quickly it comes on over 1 to 2 weeks, I would think it'd be a little bit more on the viral and bacterial side than more with a chronic condition that we're seeing at this time.
Amazing.
Okay. Yeah, I can continue. So just to talk about the histories, there's no past medical history. He's always been healthy. He's been healthy up until this point of this life, never been hospitalized, doesn't see the doctor regularly, takes no medications, has no allergies. Nobody has any neurological, autoimmune, cancer history in the family. Social history, He is sexually active. He occasionally uses protection, not always. And in terms of travel, there's been no travel out of the state. He lives in the state of in the East Coast, in the kind of southeast area of the United States. And other than that, he does admit to using marijuana, but he denies using tobacco, and he says he only occasionally drinks alcohol. And there's no known medication or other allergies. And then I will go on to the exam, since that was a short kind of aliquot. So in the exam, so this is the exam that's now it's been 2 weeks. So the ER visit was about 1 week, and now this is 2 weeks. So on the 2 weeks at the end, his roommates did find him on the sofa, and there was frothing from his mouth, and sent him to the ER, where he was evaluated by medicine, neurology, and also eventually rheumatology. So I'll kind of just kind of summarize all of the exams there, starting with the neurological exam. So actually starting with the vitals. At this point, he did have only a low-grade fever of 99.9, but all the other vitals were stable, like respiratory was stable, heart rate, blood pressure were both normal. On the neurological exam, he was awake, and he was actually alert and oriented to person, place, and month. And this exam was done actually, this was like the best exam they could do when he was like most conversant and most appropriate. So he was interactive, and at that time, he didn't have any auditory or visual hallucinations. He was able to do naming, repetition, calculations. He was able to actually say the month of the years backwards, but it was a little bit slow, but he was still able to do it. In terms of the speech, there was no aphasia or dysarthria. It was clear, fluent. And then in terms of cranial nerves, his pupils were equal 3 millimeters reactive to light bilaterally. The visual fields were full by confrontation. The abnormal thing that they saw in extraocular exam was that there was opsoclonus with extraocular movements in all directions, as well as a primary gaze, which abates with fixation. The other cranial nerves, 5, 7, 8, and 9 through 12 were otherwise normal. On the motor exam, he had normal tone, and he was 5 out of 5 strength everywhere. And the sensory exam was also normal, and there was no extinction. And in addition, he was noted to have the neck stiffness with the meningeal signs, like it was positive for meningismus. In terms of the cerebellar exam, he did have intact finger to nose, but his left hand, when they did the finger taps, it was slow. And he also was having difficulty with rapid alternating movements on the left upper extremity. Otherwise, for the reflexes, they were normal. There were 1+ diffusely symmetric, no Babinski, and no clonus. And then in terms of the non-neuro exam, the systemic exam, he had a conjunctival injection, which later was evaluated by optho. He had no lymphadenopathy. His heart and lungs were normal on exam. He had no rashes. He had no issues with any of his joints or muscles. So essentially, like systemically, everything was normal except for the eye, for which optho saw him. And the ophthalmologic exam was notable for anterior chamber cells and vitreous haze bilaterally, which was suggestive of a mild anterior uveitis bilaterally. And that is the end of the exam.
Okay, this is amazing. Yeah, I love this so much. Okay, so I think for me at least, when Jeffrey mentioned the possibility or like the opsoclonus on the eyes, that was like a trigger on my mind. I was like, oh my God, there are a lot of autoimmune encephalitis, and I think of them as like onconeural or like associated with a paraneoplastic syndrome, and then the ones that are not necessarily associated with a neoplasia in the background. And when it comes to opsoclonus, that can have a syndrome of opsoclonus and myoclonus, we usually think about anti-GABA A, encephalitis, which is, usually would present in this age group, would present with very hard to treat seizures, and would present with opsoclonus myoclonus, but I think it's more commonly present with a stiff syndrome, a stiff person syndrome, sorry. And then we also have the possibility of this being a paraneoplastic issue presenting with opsoclonus and maybe in a little bit with myoclonus as well, in which we were thinking about, I think it's anti-MA, the antibody that we'll be thinking about. However, when Jeffrey also mentioned, and then just to close that possibility of an encephalitis happening here, we also have some signs of the meninges being inflamed, and then some the cerebellar signs with problems with alternating movements. However, I think when you mentioned the opto exam, the possibility of an uveitis, that made me wonder of more like an inflammatory but systemic syndrome going on. I'm not really familiar if like an uveitis would make me think about something specifically, but I would probably wonder, okay, is the brain affected? Is the eye affected? What else can it be affected? Like, we'll probably look to the ears first. We love to talk about B syndromes here, and I think that will be a possibility to explore in this case. But yeah, what are your thoughts, Gwen?
Yes, excellent case. So, uh, very much agreement with the meningeal localization that occurs there too. The opsoclonus, very interesting. Very much, I tend to think of more in the cerebellar, around the brainstem when I'm looking at the oxyclonus. Of course, so we at least get that with the eyes. And I apologize. Did you say if he had nystagmus with eye movements in each direction here? I apologize if I missed that.
No, it looks like, well, this is just what I'm getting from the
Sure.
neural exam that they did, but they didn't mention nystagmus. They said that it was, let me see, opsoclonus, and that in all directions, and they said the primary gaze abates with fixation.
Okay. All right, so we're talking about the abating here too, because I always like looking at the eye movements with the cerebellar examination. The limb cerebellar exam seemed actually quite good. Clonus actually with paraneoplastic syndromes, particularly those affecting you. Now, we get a little bit of altered mental status that's fluctuating. You don't usually see that. When something attacks the brainstem, I'm not sure that it would fluctuate as much with it there too, but I'm certainly worried about certain cerebellar signs. Now, when we're talking about the limb movements, I'm not really hearing so much cerebellar. I'd be interested to know exactly the characteristics of the gait, though, too. That is one thing that kind of interests me. But we're talking about difficulty with slowness with speech, we're not talking about aphasia. We're not talking about dysarthria. And sounds like we're having some difficulty with said finger taps and rapid movements with the left arm, although it has normal tone. It's just seeming a little bit slow. Just almost seeming. I almost wonder if there's anything that would be related with the basal ganglia with that too. With the basal ganglia, it has a bunch of inhibitory signals within it, and saying it go, no go, and it's responsible for a lot of complicated movements. We have a younger person. It's not sounding like a Parkinsonian type symptom, but the brain basically with a with certain basal ganglia symptoms can often seem a bit frozen, if you will, and things can be a little bit slower. That is one of the things that we would be considering that would be occurring. And I do know there were the Zofran, whether that would still have a component with it on that area as well. Talking about the sensation being intact, that kind of rules out kind of like a sensory ataxia that would be occurring. The vital signs were quite good. You're mentioning somebody from the south, a little bit, some sexual activity happening occasionally. We're talking about anterior eye that happens. So we're talking about, could there be any infectious causes that you might be looking at? Syphilis would not be common. HIV. As per some of the pauses, some of the areas, and I apologize, I regress. I should go back to some of the localization. We're dealing with the anterior uveitis. Could we be dealing with a reaction with some substance, if you will, something that's laced that would be a little bit more systemic that you'd see like with a reactive vasculitis, for example? That wouldn't be the top of my differential that would be occurring. Could that be causing something else systemically that is occurring? You do see that on rare cases. Could we get something that would be infectious that would take care of that would infect the meninges? that could infect multiple areas within the cerebellum, the the subcortical region, maybe around the basal ganglia, for example, and in the parietal occipital region. Can we, and with that, can it be infecting the eye? I need to look at my overall HIV with the anterior uveitis right here, but I mean, that would be one question that I would have looking at something systemically that would be occurring. Um, and I mean, this has been happening over 2 weeks. You're talking about, if we're talking like meningitis that's happening, and if we're talking like a viral meningitis, I think they'd be looking a little bit more, lot more sick actually. And even if we're having any kind of seizures that are occurring. So I would lean a little bit more towards a bacterial cause in this particular case. Um, and this sounds a little bit too fast and quick for something like sarcoidosis, for example, which is a mimicker of many things. So I don't want to go out too far on that area as well. But things that I am thinking of are certainly immune-related, inflammatory, and that particularly we're dealing with the eye. And the fact that we're dealing with temperature in and of itself does show we're at least activating some inflammatory pathway that is happening. For something a long-term rheumatologic like lupus or anything to go on, it's a bit, again, too fast for that to occur. So that would not be one of the first things that I would be thinking of as I look over this case.
Okay, awesome. I'm excited to share the labs now and the CSF studies. So with just the basic labs, starting with the CBC is completely normal. There's normal white count, no anemia, no thrombocytopenia. Um, and then going on to the electrolytes, the BMP and the CMP. So again, the kidney function on admission was slightly elevated with a creatinine of 1.3. Just to kind of really just summarize and make this easier, I'll say that the sodium was a little bit low at 129. They did the studies to show that it was hypovolemic hyponatremia, which actually did resolve with fluids. And he had, on urinalysis, there was no blood or protein to signify inflammation, but there was ketones to signify that the patient had not been eating. Otherwise, the rest of the CMP was normal, like the glucose was normal, the liver enzymes were all normal. The CRP and ESR were taken, and the CRP was mildly elevated at 1.6, and the ESR was mildly elevated at 34. The LDH was checked, and it was normal. The CK, or the creatine kinase, was also checked, and that was normal. Then going on to some of the infectious workup, they got HIV, hepatitis A, B, C, D, and E, so all of the hepatitis, syphilis, quant TB gold, and those were all negative. Then some of the other atypical infections, given the area that he's in and given that it's affecting the eye. So they checked the CMV, EBV, VZV in the blood for PCR, and that was negative. They checked antibodies to Bartonella, Brucella, and those are also negative. And they also checked fungal studies. In the blood, they checked for crypto, histoplasmosis, and blastomycosis, and those were negative as well. Oh, and I forgot to add one more bacteria that we added was for Listeria, because of the possible meningitis, and that was also negative. And then as far as the rheumatologic workup, he got a large rheumatologic workup, including ANA, RF, CCP, complements, ANCA, ACE level. Those were all negative. So essentially the whole rheumatologic workup was negative. And then in terms of the CSF studies, he got a CSF that showed a white blood count that was elevated to 48. There was 90% lymphocytes. The red blood cell count was elevated at 45. The protein was elevated at 124, and the glucose was normal. And then some of the studies that they sent that had come back at this time with the CSF was a meningitis PCR biofire panel for multiple infections, including viral, arbovirus, and bacterial infections, and that was negative. They did send the AFB cultures which takes some time to grow, but at least the AFP stain was negative. The regular cultures were negative. They took cytology, and that was negative. The ACE level was taken, and that was slightly elevated at 46 in the CSF. And the soluble IL-2 receptor was also taken, and that was elevated to 346 in the CSF, and hence why rheumatology was consulted for, could this be a neurosarcoidosis? And then finally, they did a flow cytometry to look for lymphoma, and that showed a predominance of lymphocytes, mostly T cells, and some of them were morphologically atypical, but they said it was likely reactive. There was no clonal populations. There was very few B cells, so they couldn't rule out a B cell lymphoma. And that's the end of this outline.
Wow, this is so interesting. Okay, so yeah, I'm for sure a little out of my depth here with all the negative tests, but I think, we've been getting the sign that is quite an inflammatory syndrome that we're dealing with, and now we have, the CSF studies to make progress on what type of inflammation could lead to this pattern. So we have the lymphocytic pleocytosis with the elevated WBCs, the elevated protein. What could lead to this? Usually we think about, viral infections causing a raise in like the predominance of lymphocytes. However, as Gwen mentioned, we are a little late on the time course for this to be viral. And so other things that could lead to a lymphocytic pleocytosis are inflammatory conditions, such as, for example, Sjogren's, Behçet's, lupus, sarcoidosis, then other like autoimmune conditions like ADEM and paraneoplastic conditions as well. So I'm wondering how we can make progress. I'm not completely sure if I trust the ACE level, just because recently one of our mentors here in the CP Solvers mentioned how the ACE levels are a little useless because they lack sensitivity and specificity. However, and I know that the IL-2 is more reliable. How I'm not so sure um, how much I could trust it. So I would rely on rheumatology for that. And then maybe the other thing we could do is go for some imaging, some MRI, to find exactly what it is. I think so far we're getting the flavor that the posterior fossa or maybe like a rhombencephalitis type of picture is going on. However, I would also like to know if any other part of the brain and spinal cord is affected, so that based on tropism, maybe we can make more progress with the etiology of these conditions. So yeah, those are my thoughts. What are you thinking, When?
All right. Yeah. So really good thoughts. I mean, it's one thing that I've got to think about too. You're thinking about seizures. If you're thinking about the CSF, I mean, you're talking about a lymphocytic predominance and normal glucose there. You're wondering if something is viral that is happening, and you're thinking seizures, thinking red blood cells. That's not going to be the case in this, because I assume that the HSV came back negative when you're talking about the panel there too. But something else that I probably should have mentioned there as well, because when you're thinking of seizures with an acute infection and red blood cell counts, very, very commonly temporal lobe HSV actually would be well within the realm of this patient too, that I hadn't mentioned. That is an important thing to be thinking about that he does not have. If he was a little bit north, like here in the Northeast where I am, obviously, you said Borrelia, I don't know if it was checked right there too. Lyme would be one thing we'd be looking at here too, but again, not the case here as well. They looked at a lot of rheumatologic studies that they'd gone through, ruled out a lot of things. Now, the ACE level, it's you get a lot of ACE levels, and how much you can trust it. I'd agree as to how much trust you have with it. However, I wouldn't necessarily throw away an elevated ACE level or an IL level too. And I think it would be certainly be within the realm to be considering neurosarcoidosis as one of the possibilities that can be occurring here as well. And I do very much agree with getting an MRI of the brain. So we are localizing, at least with this, the brain, the cerebrum, the meninges here. Spinal cord, main thing, we're thinking of the spinal cord, any myelitis here. You said the reflexes were about 1+. and we're not getting any sensory level. And I mean, we're getting some dysautonomic, and talking about autonomic symptoms, I mean, mainly if dealing with the bladder or the bowel right there. Anything that bladder, it can be a certain level. If you're talking about systemic dysautonomia, it'd usually be above T6. But I'm not overly convinced at this time of any clear myelitis, and it really doesn't sound anything peripheral from what you're describing, particularly with the examination. So I think we're dealing with above the foramen magnum, at least in multiple areas, and possibly a meningeal if you're going down below the foramen magnum that's occurring. I would, in addition to seeing the MRI of the brain with and without contrast, you certainly want to see the inflammation here too, that could occur. It sounds like a vasculitis is less likely, but when we're getting it, I would actually want an MRA with vessel wall imaging to see if there's any inflammation of the vessel walls. As we're looking at it too. And this would be along more of the rheumatology part. If we're thinking sarcoid, would it be getting a chest x-ray? Would it be getting a CT chest, abdomen, pelvis? We're talking about the obsoclonus myoclonus. So in practicality, when they're here as an outpatient, I'm still going to be thinking. I'm also going to want to make sure there's no lymphoma. I'm going to want to be thinking, is there anything at least neoplastic to be ruling out, but certainly with any kind of neurosarcoid, I might just go ahead and do a CT chest, abdomen, pelvis to look in that region, see whether systemic signs or symptoms are occurring as well.
Awesome. So I only have, like I took these images myself. So I only have the MRI brain images and I just selected a few for you guys to look at, which I can share. But before that, I can tell you just to answer some of the questions, the MRA with vessel wall imaging black blood protocol was done, which was completely normal. And the MRI C-spine, T-spine, L-spine didn't show any evidence of myelitis. And let me just share, let's see if I can share my screen. Okay. I'll show some images of the MRI. So we'll see how good of a job I did of picking out the MRI images. So these are, so since, I heard you guys mention brainstem, cerebellum, this kind of area, I chose, these are T2 flare images, and none of the other sequences I think really had anything different. So this is just the T2 flare in two different slices. And I'll let you look at that first.
Okay, so yeah, thank you, Jeffrey, for pointing that out. We're seeing T2 flares on the axial cut. What am I seeing? I think usually, when it comes to imaging, I look for asymmetry, but it's completely fair that there could also be, symmetrical lesions. And I think right now, I would be looking for like meningeal enhancement. So like some thickness and some brightness on the meninges that are covering the structures. And maybe some hyperintensities that could account for the Roman encephalitis type of picture that we're seeing. I think I'm seeing some brightness on the second imaging, on the second image of the, so on the left, I think we're at the level of the medulla, left medulla and left cerebellum, left of the cerebellum. I think I'm seeing some like more brightness in compared to the right side. But yeah, I'm not so sure really. What do you make of this MRI, Gwen?
So yeah, I mean, as I'm looking at it, looking at the cerebellum right here, it's looking pretty good overall. Let's look at the periaquedual, the fourth ventricle. I would want to see it a little bit more 2D, but could there be some questionable hyperintensity? And I agree. One thing you'd want to be looking at would be the meninges. I want to look a little bit higher with the meninges here too, making sure that those are not enhancing for a number of reasons. Want to make sure things symmetric or asymmetric. I'm not quite being. We're not at the level of being able to look at the dural sinuses yet. As I look on the left, I think I might be able to appreciate a little bit of meningeal enhancement, a little bit more on the left portion and on the right. And of course, if you're looking for meningeal enhancement, you want to know if it's smooth or if it's asymmetric. I'll be honest, I want to look at more of the brain right here too, but it looks a little asymmetric if we're looking at any of the meningeal enhancement on the left compared to the right.
Okay, I have some more images, and of course, I apologize if like I as a rheumatologist have to pick these. So, these are other images. So these are the, I believe this is the T2 flare image on the left, and then on the right, this is the SWI, and this is just a different cut.
Okay. What am I seeing? Honestly, I think we do see more on this flare, maybe more of the meningeal enhancement. I think it's a little, I don't know if it's because of the cut itself, but it seems a little discontinuous, like a little patchy. We're seeing some brightness and then some darkness and then some brightness again. So that would be interesting. That could fit the infiltrative hypothesis that we have with sarcoidosis for sure. Malignancy will be another thought, and then like IgG4 disease is another one that could present like a pachymeningeal patchy type of enhancement. I'm not really seeing leptomeningeal enhancement, like anything going into the sulcus of the brain, not that I'm noticing. On the left side of my this image. And then we have the SWI, where we use it a lot for like bleeding, to see if there's any bleeds that would be very dark on this sequence. And I'm not sure if I'm seeing anything asymmetric, but I would say that I'm not really super confident with this septum imaging to know necessarily if, the deep vessels should be as dark as they are right now. So I would totally defer to you when for your expertise.
Sure. Yeah. So I agree. And this is a good acute observation talking about pachymeningeal versus leptomeningeal enhancement. Pachymeningeal being around the lining around the top of the brain, the pachymeninges. And certainly IgG4 would be one thing that you'd be thinking of here too. If it's smooth and diffuse, the most common thing that would be happening, in addition to idiopathic, would be a CSF leak, which is not the case that we're looking at right here too. That's the most common cause of diffuse enhancement, and it looks quite patchy to me in multiple areas. With that, that's where you can get multiple etiologies that can be rheumatologic, of which the labs so far have come back negative. That's when it can be neoplastic. You're talking about, is there any kind of lymphoma? And I know that's been looked at right here too. Certainly sarcoidosis can cause a patchy kind of enhancement that would happen as well. And as far as the MR, the imaging right here too, I'm not seeing any diffuse bleed that happens. You get a little bit of some larger internal blood vessels moving out, but it's actually seeming. I would Some of the areas, you see a little bit of larger vessels compared to the others, but I'm really not seeing anything that's particularly abnormal. I'm not seeing any bleeding within it. And of course, think something that would complement the SWI would be the MRA as well, with that being normal. I don't know that I'm overly convinced of anything being abnormal. Biggest thing with the SWI is you want to make sure there's no bleed, anything outside of the blood vessels that are occurring. And I'm not seeing any microhemorrhages, not seeing any angiopathy that is occurring within it. So any kind of amyloidosis would not be as likely to be occurring here. We're talking about the stiff neck. You'd want to be ruling out any kind of subarachnoid hemorrhage. And that could be occurring here as well. You do see a little bit on the right sulci that's happening, a little bit of enlarged blood vessels, but I'm not really seeing a clear hemorrhage that would be occurring there, and it seems pretty consistent with the other MRIs. So the big component with this seems to be the enhancement of the meninges, of which I'm concerned about either an infiltrative or an autoimmune or an enhancing process. I will note that the blood vessels are a little bit enlarged on the right there, but I'm not seeing anything that really would that I would say that I would excite me on that so far.
Yeah, and just to help you guys a little out, this MRI brain that I'm showing you is read as normal, like completely normal. So like I am showing you the images, but like just keep that in mind, just so you don't have to overthink things. And I won't show you too much the DW80C unless you want to see it. But the whole thing was read normal. But this is the last slide that I actually want you to see in the MRI brain. And this is the T1 post contrast.
Okay, yeah, this is what we were talking about with Lucas on the chat. I assumed that it was like a post or like contrast enhanced T2 flare, which is never good to assume. But yeah, thank you so much for clarifying, Jeffrey. And I think with this T1 post contrast, we are seeing some leptomeningeal enhancement, if I'm not mistaken, when because the sulci should not light up as spider webs that are, I think that's what it's looking like right here. I'm also seeing some pachymeningeal enhancement, so I think that's still beyond what we would expect from our hypothesis. I would just mention that when it comes to like the leptomeningeal, as Gwen mentioned, we're thinking more like typical infections. And when it comes to pachymeningeal, we think about more atypical infections like TB, syphilis, and then infiltrative processes like malignancies and rheumatological things as well. So yeah, what do you think, Gwen?
Yes, and as I mentioned, I'm talking about symmetry. Is it like a smooth? I mean, you're not seeing any huge like lumps, if you will, was as it expands, but is like a smooth pachymeningeal enhancement, or is it asymmetric? This appears asymmetric to me. You can still see the blood vessels with the enhancement. And now I see the transverse. I'm sorry, this is the sagittal sinus. That looks pretty. That looks quite good and full there. So that does not seem abnormal. But as I look at it, I am a bit of a concern for an asymmetry that does occur, which would put us more on the inflammatory, rheumatologic, or infiltrative kind of path that we're looking at. And this is a patient who is having cerebellar signs, who is having hallucinations, who is having fever with it there too. So again, I'm still very much on the inflammatory, infectious, autoimmune component that would be causing this, and that's when I wonder if they got a biopsy that had occurred, that was done, or what other studies were done to be able to work this up.
Yeah, and just out of curiosity, of course, I am not the best at reading the images, but can you guys see my mouse here at
I can
all?
now.
Okay, so if I pointed out these areas right here and you see these lines coming out of both sides, is that something that is bringing any clues? Does that mean anything to you guys?
It does to me. I I don't remember exactly what it's called. It's something like zebra or tiger or something like an analogy like that. Weird. I'm not really sure if it's like pathognomonic or something. I remember a patient that I had that had this type of, I'm not sure, like tigroid pattern or something. Um, but I believe that patient ended up having an autoimmune encephalitis. But I'm not sure. I would love to learn from you, Jeffrey, or when. I don't know
So
if this rings a bell.
So I'll be honest, I have not seen as much of that right there too. That's that. I mean, that's when you're going moving out from the brain, you're working with the venous system that's happening, that is enhanced and lit up right there too. So you're dealing with inflammation of the veins going out. But I'd also look to you, Jeffrey, to see exactly what kind of condition would cause this. I am concerned about an autoimmune process or that could be occurring, but we do have enhancement of the veins that is occurring, lighting out. So I'll be honest, I don't remember the exact syndrome this would be associated with.
Awesome, awesome. And there's this one more last aliquot, and then I'll ask you like essentially, like final testing that you would do. And I'll just keep this screen up right here. And so the last aliquot is just like based off of these findings, as you had suggested, we wanted to make sure that there was nothing rheumatologic, nothing systemic, like a systemic infection, systemic anything, lymphoma going on. So we did pan scan the patient with a CT chest, abdomen, pelvis, and that was completely normal. We also get a testicular ultrasound because, as Vali mentioned, sometimes you can even get like paraneoplastic syndromes there. That was normal. And echo was normal. And so essentially the whole systemic workup was normal. And we were able to localize this to primarily in the neurologic system. And I'm wondering, like, in terms of like, if you were to send some tests, like which, testing that you could send here.
Sorry, I got a little distracted here. Yeah, I I would I'm not really sure. Honestly, I googled the pattern that I was talking about, the Tigre pattern, and I don't think it fits this one exactly. And the Tigre pattern that I was talking about, um, oh, perivascular enhancement pattern. Okay, this one I know about. Kirtan shared a paper with me about it, and they were talking about. I mean, they talk about a lot of things that could cause perivascular enhancement, including like demyelinating things and um, I believe MOGAD is typically the one that causes perivascular enhancement. But I remember that paper, there were like a billion things that could cause perivascular enhancement, including malignancy and sarcoid, if I remember correctly. So I'm not really sure. I think if there's not any other place to biopsy, and I don't know if I would feel confident biopsying the meninges like here. Um, So yeah, no, I'm honestly a little bit lost for words. What are your thoughts, Gwen?
So, I mean, we're dealing with a CNS vasculitis, which is like you got to rule out everything else first as it's occurring here. If you're only thinking of the CNS, that would be occurring and causing this here too. Um, Oh, you can still have me on right here. Sorry, I have a couple of technical difficulties. MOGAD, I mean, a good thought. We're not seeing any clear demyelinating processes that would be happening with it. Um, One thing about if we're thinking that this could be a vasculitis, you're talking about the risks and side effects of a biopsy versus the risks and side effects of an untreated vasculitis. If we have a high enough suspicion that that's what it could be occurring, I would still go for the risk of a biopsy. To be honest, could we be dealing with any lymphoma that's occurring? Because I know that was one of the concerns there. We could always get a peripheral blood smear to make sure that this isn't a clear lymphoma before getting the brain biopsy. Sarcoidosis, I'm still not totally unconvinced that. I don't know how often you see a general primary only neurosarcoidosis. I know it can happen. But even then, a biopsy would be able to help. We certainly do have it. Certainly do have it occurring within. Sorry, I'm making sure I'm still on. Within the meninges that is occurring. So honestly, if it's primary CNS and we've ruled out everything else systemic, and we're talking about the risks and benefits, unless there's another test that we would be able to go with, there's certainly risks with getting a biopsy, but I would think that the risk of getting a biopsy would be lower than getting the risk of getting an untreated CNS vasculitis. And of course, if we're talking about doing it empirically, well, we're not talking benign medications that we're given either, especially if we're dealing with sarcoidosis. I mean, we don't want to be hitting sarcoidosis or CNS vasculitis with the same medications. So this is dealing with a lot of big differences in our prognosis. And when you get an inflammatory insult with the CNS here, I'm often thinking of some of my patients that end up being debilitated when they're not treated fast enough versus those who are. So it's certainly a conversation that you'd have. But I think in this case, as long as we've ruled out everything else and went with everything else, I would be a little bit faster with the biopsy.
Okay, amazing. So, this was a very, very tricky and challenging case that, I love to present this because just the story was so fascinating. So the end diagnosis of this is a really rare condition that was only recently discovered. It's an autoimmune encephalitis called GFAP. And it's almost like a vasculitis, but the key difference is it causes a small vessel vasculopathy or vasculitis without causing the microhemorrhages that you would necessarily see on the suite. And the other thing that's interesting, it looks very similar to neurosarcoidosis, but it's very acute. And so we were lucky because the plan, as Dr. Zeigler mentioned, this can occur in addition to lymphoma as a perineoplastic syndrome, or even it can co-occur, for example, with a CNS infection or vasculitis, right? So a brain biopsy was definitely on the table. We were very lucky that with the autoimmune encephalitis panel that we sent, including the GFAP, it came back and it was positive in the CSF. And what that allowed us to do was treat this patient with steroids and immunosuppression. So I just wanted to highlight that this is a very interesting, kind of very tricky scenario in which fortunately we were able to avoid a brain biopsy because it ended up being a rare autoimmune encephalitis.
Amazing. No, thank you so much, Jeffrey, for bringing this case. I know about GFAP, but I have not read about it yet. It's still on my TBR. And I mean, this case has put it as a priority now because I do want to be familiar with how this disease presents. I know that it's kind of, you know, a little bit on the spectrum of the autoimmune encephalitis and the demyelinating disorders as well. So I think that's very interesting. I also want to highlight, the power of imaging for this case, like the perivascular enhancement. I was just looking at Kirtan's list that came from the paper that I was referring to that he shared with me, and how just like identifying that pattern of perivascular enhancement could allow us to make such progress that you and your team you felt comfortable not doing the biopsy, right? So I think that there's a lot of power in that, and that's one that I'm trying to be better at. So yeah, no, thank you so much. Gwen, do you have any reflections or teaching points that you want the public to take away?
Yes, a spectacular case. Thank you so much. So, said rule out everything. It's good to wait for the autoimmune panel to come back. And I will go over and remember the vascular enhancement with the GFAP. Now, it's interesting. I've actually seen one that was rarely involved with actually a AIDP-like syndrome and responded to steroids but didn't respond to IVIG. But I have never seen another one like this with regard to primarily CNS involvement. So excellent case and excellent teaching points. Another good thing is to rule out everything before you assume a CNS vasculitis or any other similar symptoms.
Great. So just before we pass the mic to Hans for teaching points, I just want to thank you, Gwen, Dr. Zeigler, for being with us today. It was a treat for sure, and we look forward to having you back for more and more discussions.
It's been my honor. Thank you so much.
Amazing. So with that said, Hans, you take it away with the teaching points.
Okay, thank you very much. This was really a steamroller for a case. We had a patient who came in with a wide spectrum of symptoms from acute encephalopathy. It has insomnia, gait imbalances, auditory, visual hallucinations, headaches, stiffness, neck stiffness, difficulty walking. It was at this stage almost impossible to focus on one particular area in the brain. And the idea that we had at this early beginning was, could it be an autoimmune disease, an infection, post-infectious problem, or prodrome, or paraneoplastic? Also, according to the patient's HBI, we had the possibility of metabolic and toxins that could be playing a role, or just a vasculitis or vascular problem. The white DX, Kirtan gave us a really big one, and this is just a small example, would be ADAM or anti-NMDA, NGIE, mitochondrial neuro gastrointestinal enhancement disease as one possibility, because the patient also showed up with nausea and vomiting, or OMAS, opsoclonus paraneoplastic neuroblastoma syndrome was another possibility that was mentioned because of the patient's opsoclonus and ataxia that he presented with. Eventually, to make this teaching point a little bit shorter, we looked at the CSF, and that was basically not too abnormal. It showed a high lymph cells, so as well as ACE in and IL-2 elevated. So this was again the thought of, is it a lymphoma, ACE elevated sarcoidosis, but it's highly unspecific. In the end, it was a tiny little spike from the ventricles in the MRI that has given us a clue where to search further, and that was the enhancement radiating from the ventricles, which is very characteristic of anti-GFAP, an autoimmune glial fibrillary acidic protein serology syndrome, which is then proved via serology with anti-GFAP IgG. Thank you very much. And that was a big case with a totally unexpected outcome. Thank you.
Thank you. Have a great day.